Blood the heart pumps out every time it contracts. And you can calculate the amount by multiplying heart rate with the stroke volume. And some things determine, sorry, wait, I can't see. Okay, yeah. Some things that control how much the blood increases or decreases, or how much it is in general, are preload, afterload, contractility, and the heart rate itself. So preload basically is how much blood enters the heart. So how much blood we're using to fill the heart. And diastolic volume means at the end of the diastole, which is relaxation of the heart, how much blood there is inside of the heart. So it did not contract yet, no blood has left the heart yet. Afterload is the resistance against the resistance that the heart has to pump against. So, for example, if the aorta, and I'm sure everyone knows the aorta is the vessel which the heart pumps blood out to. So, if the aorta, for example, has some sort of narrowing or some blockage, the afterload will increase. So, it will be harder for the heart to pump blood out. Contractility. Contractility is basically really just the muscles, the heart muscle itself contracting, how strong it contracts. And then heart rate is the speed of the contractions. So it's beats per minute. Okay. Yeah. And what regulates the cardiac output? Some other things that regulate it. So intrinsic factors, like, for example, Frank-Starling mechanism. So the Frank-Starling mechanism says that the more the preload, the stronger the contractility of the heart, and the bigger the stroke volume. And also some extrinsic factors, like, for example, sympathetic nervous system. When your body is in fight or flight mode, the heart rate is increased, or parasympathetic, which is also called rest and digest system. So the heart rate decreases. Some hormones like adrenaline, thyroid, and thyroid hormones. So in hyperthyroidism, for example, when the thyroid is overly active, you would have increased heart rate. Okay. Work of the heart. So basically, these are just a few equations that are mentioned in your lectures, and I think you should remember them for your credit. So stroke work would be pressure times volume, and the total work is the stroke work that you just calculated above times the heart rate. And then the heart energy sources. So where the heart gets energy from to contract in the first place is the main source is fatty acids, but it also uses glucose or lactate in case of hypoxia. And oxygen consumption depends on the wall tension and contractility and heart rate. So if obviously if the heart is contracting more, it's going to need more oxygen than normal.
Yeah, and the energy sources, there were a lot of questions that we got from that, I remember.
Yeah, so just focus on that point. Okay, so now to mention a few specific circulations that are also mentioned in your slides. So the heart itself, to be able to function, it needs blood as well, which is provided by the coronary arteries, and it receives 5% of the cardiac output that we previously spoke about. And the coronary arteries fill during diastole. So when the heart is in, let's say, relaxation mode, when it's not contracting, when it's not releasing any blood, that's when the coronary arteries fill with the blood that can provide the heart with energy and oxygen. Regulation. So regulation can be by the local metabolites like adenosine or nitric oxide. It can cause vasodilation of the coronary arteries, or autonomic control, which we previously spoke about as well, like sympathetic system or parasympathetic system. Some pathologies that can happen are ischemia, which is lack of blood flow, and it can cause angina. Angina pectoris is basically chest pain due to lack lack of blood flow to the heart itself. So the heart muscle isn't getting enough blood that it needs to function normally. Or myocardial infarction. Myocardial infarction basically means that since the heart is not getting enough blood, the muscle cells will die, so they will stop functioning. Okay, and then now for the cerebral circulation, so how much blood the brain gets. So the brain requires 15% of the cardiac output, and there's autoregulation. So autoregulation basically means basically all of us have a normal blood pressure range, but sometimes it can deviate. You can have hypertension, which is high blood pressure, or hypotension, which is low blood pressure. So in that case, obviously we can't just die because then everyone would be dead. So our body has a system of autoregulation in case of those deviations happening, so we can regulate and we can try and attempt to give the body organs enough blood supply. So this autoregulation can happen between 60 and 160 millimeters mercury of blood pressure. It can happen by myogenic mechanism, which is basically the vessels themselves have smooth muscle, so by the constriction or dilation of those vessels, or by metabolic control. Like, for example, if you need more oxygen, you can, I don't know, hyperventilate. If you need to get rid of carbon dioxide, you can also hyperventilate, and so on. Also, there's the blood-brain barrier, and it limits permeability to the brain to prevent harmful substances from reaching the brain. And yeah, to just provide the things that it needs, like oxygen. Wait, go back. It's okay, it's okay. For the pathologies, there's, for example, stroke. Stroke is if there is, I mean, you don't really need to know exact details right now. This you'll take in third year. But stroke is when there is also lack of blood flow. Like we spoke about the heart. So here as well, lack of blood flow. It can be for various reasons, like a blood clot or something. And cerebral hypoxia is obviously lack of oxygen in the brain. As for the pulmonary circulation, it's a low pressure and high compliance system. And Katie, I believe here we're speaking about the nutritional circulation, not the functional circulation, right? Like the lungs
Sorry?
themselves, like the lungs themselves getting blood
Yes.
for their own function. Yes. So it's the low pressure and high compliance system. The pulmonary vascular resistance is low. But in hypoxia, there can be vasoconstriction. And that is so that the blood goes to areas of the lung where there is more oxygen. So the blood can receive oxygen and function properly. And some pathologies here that can happen are pulmonary hypertension, which is self-explanatory, so increased blood pressure in the lungs, or pulmonary edema. Pulmonary edema is when there is fluid in the lungs, which is normally not present. That would be pathological. It would be a disease, not normal. Okay. As for the renal circulation, so here we're going to speak about the kidneys. They need 20 to 25% of cardiac output. The functions of the kidneys are filtration, waste removal, blood pressure regulation. That isn't very CVS, that's more of kidneys, which I think you'll take later. Yeah. And for the regulation, we spoke about why autoregulation happens. And here the values differ. So here it's from 80 to 180 millimeters mercury where autoregulation happens. And it's by myogenic feedback, like we mentioned previously, and also tubulo and glomerular feedback. The glomerulus having more or less blood by the afferent vessels, vasoconstricting or vasodilating. Some hormones that can be involved in that are the RAS system, so the renin, angiotensin, aldosterone system, or ADH. ADH is for increased, when it's increased in the body, there would be increased water absorption from the renal tubules. Okay, you can move. As for skeletal muscle and skin circulation, so for skeletal muscle, during exercise, our muscles are working more obviously, so they need more energy, more blood supply, and more oxygen. So there's vasodilation in the skeletal muscles, and that happens by local metabolites and beta 2 adrenergic receptor activation, which is sympathetic. As for at rest, there would be sympathetic vasoconstriction because right now they wouldn't need as much energy and blood as they do during exercise. As for the skin circulation, so we have thermoregulation. So, for example, when it's hot, when your body's feeling hot, we need to get rid of internal heat. So, to do that, we vasodilate. So, more blood goes to the surface of the skin and the heat radiates off. As for in the cold, we vasoconstrict. Why? Because we want to retain the heat. So we don't want to lose the heat through the blood going to the blood surface and whatever. So we prevent that from happening. And that happens by sympathetic control. So in the cold, we vasoconstrict, and in the heat, we vasodilate. Okay.
Yep, thank you, Ella. Guys, so we kind of started from the end of your CVS lectures, and that's only because Ella has to leave. But so whatever Ella had explained comes towards the end of your CVS. So like I don't know if the professor has even finished that portion, but it's interesting. So we're gonna now start from the beginning of your CVS lectures. It starts from the heart. Now, one important thing that you have to know about the heart is there is four main characteristics that it kind of guides you on how the nervous system responds to anything that the heart requires. It just tells you about the characteristics of the heart, and these are the things that can change in the heart, and it's affected by the parasympathetic sympathetic nervous system. So, for example, firstly, you have automaticity, and that means the heart is not majorly innervated by nerves coming from the brain, but it can maintain its own impulses. That means it's able to generate its own spontaneous impulses. If you guys remember from Anat, the heart has its own SA node, which is able to generate its own impulses. So that's what automaticity means. Then excitability, which is able to cause depolarization in response to the impulses on its own as well. And this is done from the cardiomyocytes, the working cardiomyocytes. You have conductivity through the gap junctions, which is present between each cardiomyocyte. I think you all remember that from histo. And then you have contractility, where you go over the excitation contraction recoupling. Now, like I said, there's two different types of cardiac muscle fibers. There's the working myocardium, which works on the contraction part, and then you have the pacemaker and conductive system, which is what sends the impulses through the heart. So your pacemaker and conductive system starts from your SA node, it continues to your AV node, then to the AV bundle, the right and left, and then to the Purkinje fibers. So those are two different types of muscle fibers. Why this is important is because the mechanism of how the conduction works between both of these is different, and I'm going to explain that with action potential. Now, in the action potential, there's two different types of action potential in the heart. Now, all of you, when you were doing the nervous system, you learned one certain type of action potential, but it is not helpful in the case of the heart. So you have first an action potential with fast depolarization. This fast depolarization is seen in contracting cells, so in the working myocardium. And how it is different is it has the shape of, if you can see on the top right, it has this shape of an action potential. So it's not just where you have depolarization and then repolarization and hyperpolarization. There's also like a plateau phase and a notch. I will be explaining these, but just for now, like it's this is fast depolarization. And then you have action potential with slow depolarization, and this is seen in your conductive system, so your SA node, your AV node, and one difference between the both of this is the resting membrane potential for your contracting cells is minus 90 millivolts, while for the SA node, AV node, for your conducting system, it's minus 60 millivolts. And you can see an example of the action potential with slow depolarization on your right bottom. This picture shows you how the impulse moves in an SA node. Now, some important channels before I move into the mechanism of how this action potential goes about is you have some fast voltage gated sodium ion channels, potassium ion channels. There's many different types of potassium ion channels. For your credit, just know the names. You don't have to know the function of each of them. It's there in the lecture, but you just have to know the names of them. You don't have to know the function of each of them. Then you have the voltage gated calcium channels. It's very important to know that there's two different types of voltage gated calcium channels, and there's the L type and the T type. The L type, it lasts for a really long time, while the T type is a transient channel. So now first I'm going to go over the action potential with the fast depolarization, which is seen in the contracting cells. So I'd like you guys to kind of look at the picture on the right top. As you can see, like from the numbers, you have a zero phase, which is the depolarization. Why it's called fast depolarization is because you can see the line is very steep. Then you have one, which is the notch, where it kind of reaches its maximal point and starts to like descend. Your second phase is like a plateau phase where it kind of remains constant. And then you have phase three, which is the repolarization, where it goes back to its resting membrane potential. And then the fourth phase is resting membrane potential. I'm going to explain now what happens in each of these phases. So in your first phase, it's about minus 90 millivolts, which is the resting membrane potential. We have sodium ion channels that open, and sodium starts to move into the cell, and it happens really fast. It happens with fast voltage gated sodium ion channels, and that's why the line is so steep and it increases super high to about positive 50 millivolts. Now, once it reaches that point at the notch where you have phase one, the sodium ion channels close, and you have potassium ion channels that start to work as well. Now, something that I didn't say is during the zero phase, calcium ion channels also start to work. It's this L type long lasting calcium ion channels. Now, the thing about this calcium ion channels is it starts to open really slowly and it closes really slowly as well. So it kind of starts to open in the middle of zero phase. And but once we reach the top phase, the first phase, that is when your potassium ion channels also open. And the function of the potassium ion channels is that it causes potassium ion channels to move out of the cell, causing the membrane potential to decrease and become more negative. But like I said, the calcium ion channels, the long lasting channels, it takes a really long time to open. So once it opens, the potassium channels have already opened. And that's your plateau phase because the calcium ion channels are also open, and it causes for calcium to move into the cell. And calcium ions, like we know, it's positive. So you have calcium ions moving into the cell, making it more positive, while potassium ion channels, which are also positive, move out of the cell, making it negative. These both charges balance out, and that's where you have the plateau phase. So this is your second phase, the plateau phase. And then, like I said, the calcium ion channels, it takes some time to deactivate again and close up. Once it closes, it's only the potassium ion channels that are open, and that leads us to our third phase, which is the repolarization phase. And that is where potassium ion channels are the only channels that are open, and you have some small ion channels that are open as well, but this is your most important. So potassium ion channels are open and potassium ion starts to move out, making the charge more negative along the membrane until it reaches minus 90, the resting membrane potential, and potassium ion channels close. So this is in your contracting cells. Why it's super fast, why it's called fast depolarization is because the heart, once it gets a stimulus, it's supposed to contract right away. You know, the heart is supposed to be a single contracting system. So we're trying to be as fast as we can and as quick, I don't know what you call it, as conductive as you can. So where you have the gap junctions. So that's why you have a really fast depolarization. Now, going into the action potential with slow depolarization, it kind of looks like your, like I said, the right bottom picture. As you can see, the pictures are very different. The shapes are very different. But the main thing is the same. very different between both of these two different action potentials. Now, talking about the action potential with slow depolarization, which is in the conductive system, the resting membrane potential is minus 60 millivolts. And unlike the fast depolarization, you can see that the resting membrane is never withheld at one point. It is always increasing. You can see it goes from minus 60 to minus 40. And why that is because we have some funny leaky sodium ion channels that are always working, and it always causes for sodium ions to move in. It's at a very slow rate, but then it's always working, which is why you can never have a consistent minus 60 millivolt resting membrane potential in the conductive system. So because of this, it will increase to minus 40. And once it increases to minus 40, which is the threshold potential, it will go into its zero phase, which is pretty much the same as the fast depolarization. It's but it's not as steep because it's just much steeper in the contracting cells. So it's not as steep. And as you can see, it does not have the first and second phase like the fast depolarization. And that's because the calcium ion channels don't work the same way. And right after depolarization, you also have the slow L-type calcium ion channels that work with it during depolarization. They close, and you have the repolarization phase, which is where you only have potassium ion channels. And you do have some calcium ion channels, but then they deactivate much quicker. And then it reaches back into its resting membrane potential, and then again the leaky ion channels open, and it's never going to be at minus 60. It starts to increase again until you have another action potential that rises up. It's very simple, like the concept of it, but to understand details and how much they want you to know, I would recommend watching videos like from Ninja Nerd and Bite Size Med, where they explain more about the channel specifically. But I hope you get a good overview about both of these different action potentials. Now, the absolute refractory period and the relative refractory period, you guys already know what both of this means. In the absolute refractory period, almost all of the sodium ion channels are inactivated, and a new stimulus will not be able to arise during this period, no matter how strong it is. While in the relative refractory period, some fast sodium channels are still inactivated, while others are activated. And so, a very strong impulse can stimulate for an action potential to take place. Now, in the fast depolarization, this is what the absolute refractory period looks like. It's in the middle of the third phase where it ends, and it starts again, and the relative refractory period starts at that point and then ends before the resting membrane potential. And the whole reason for this refractory period is, we already know this, it's to prevent tetanic contraction, especially in the heart. Now, going over a small recap of what excitation contraction coupling was. I'm sure you guys learned this in ANAT, but I'm going to go over it again. So you have calcium ion channels, and these calcium ion channels, like we saw in fast depolarization, they also go in, they have an influx inside the cell, and it starts to activate some channels in the sarcoplasmic reticulum. The sarcoplasmic reticulum contains some more calcium ion channels, and so it induces for calcium ion channels to move out of the sarcoplasmic reticulum. And these calcium ion channels are these calcium ions are used for the sliding of filaments, which is this how the muscle contracts, if you guys remember. And that's excitation contraction coupling. Now, that was just a small overview of the heart. Again, like I said, do watch videos to get to get better understanding. Now, moving into the classification of vessels. Now, in our whole body, we have many different types of vessels. We divide them into two different systems: a high pressure system and a low pressure system. The high pressure system, it consists of elastic arteries like the aorta, transport arteries like just regular arteries, and then you have regulation arteries like the arterioles. And this system is for distribution, so distributing the blood into our different organs. And then you have the low pressure system, which is the capillaries, venules where blood primarily collects, and then veins, known to be the blood reservoir. And capillaries is where the blood gas exchange takes place, while the veins, both venules and veins, are collecting vessels. Now, it's quite understandable what high pressure system means and low pressure system means. High pressure means there's higher pressure in these types of vessels, while low pressure, lower amount of pressure. Now, there are some characteristics of each of these types of vessels. You need to know about them. First, talking about the elastic arteries. Elastic arteries, they have a larger diameter and they have low resistance. That means it's not difficult for blood to pass through. The elastic fibers, the characteristic of it being called elastic arteries is the presence of elastic fibers. These elastic fibers allow during systole, which is the part of the heart pumping out blood, it causes for the elastic fibers to stretch out, allowing a larger amount of blood to pass through. So distension of the elastic fibers. And then during diastole, where the heart is filling up with blood, it recoils again. And this is also kind of how you can feel your pulse. It's this distension and this recoiling of your arteries. It's obviously not the elastic arteries like the aorta, but then this process continues. It is called the Win-Kessel effect, the capacitor Win-Kessel effect. This what's it called, this distension and recoiling. But what happens is, as we move on through from the elastic arteries towards the arterioles, our arteries become much more resistant. They're not as elastic, they don't have as many elastic fibers, and so it disallows as much distension and disallows as much recoiling as the elastic arteries do. So it's also known as a pressure reservoir, where pressure is maintained, but then there's less of this distension and recoiling action. And in the arterioles, it's reduced pulsatile flow. This distension recoiling is known as pulsatile flow. And so because it becomes more stiff, there's reduced amount of this pumping mechanism. Now, the regulation of muscle tone, Ella kind of described this. We have two different types of regulation: local and general regulation. You'll have to go more in depth when you're studying for your credit. But then the local mechanism is, for example, when there's high pressure in a certain area of a vessel, it stimulates the release of nitric oxide, or something that not nitric oxide, sorry. It'll cause for vasoconstriction to maintain a high pressure and disallow large distension. And these are, so local is like in your local area, while general would be activating the sympathetic system or the parasympathetic system that controls your whole body. Now, talking about capillaries, the capillaries, like I said, it's where you have your exchange taking place, and it's got thin walls, much thinner. It has a large area to allow large exchange, and it's at low speed to again allow efficient oxygen exchange, oxygen and carbon dioxide exchange. Now, different types of capillaries have different types of permeabilities. We learned this, like fenestrated capillaries and capillaries with tight junctions, and the exchange happens through either diffusion or filtration. Now, how this works is, inside the vessels, we have an amount of we have a pressure which is known as a hydrostatic capillary pressure. This is the force that allows blood to move through, like oxygen to pass through and fluid to move into a certain organ. And yes, this is your driving force. But you have, if there's obviously, as a mechanism, if there's too much fluid moving out, it will cause for an edema or ascites, for example, and we don't want that. So in order to have just a small amount passing through, and not although our blood passing out of the vessels, we have proteins within the blood. And these proteins, like, it disallows from too much fluid moving out, because you need to maintain like a protein fluid equilibrium within the vessels. So as you can see in the arteriolar end, which is the starting of a capillary, the hydrostatic capillary pressure is 4.3. That means the driving force is 4.3 kilopascals. While at the venular end, it's 2.3 kilopascals, because that's because a lot of exchange has taken place, a lot of filtration has taken place, and fluid has moved out. But obviously, not all 4.3 kilopascals is moved out, and that's because of the oncotic plasma pressure, which tells us the pressure that's caused by the amount of protein present. I hope this helps you guys understand, but these values are just for your understanding. Then the veins are your blood reservoir. It has low resistance, it has a larger diameter, it has high distensibility, which means it's able to move much more easier than the arterioles. Now, how veins are able to bring about blood back to the heart is called venous return. This is very important for your credit, because we got a lot of questions about this. In final notes, it explains it really well, the venous return stuff. So we have valves in the veins which allow for blood to move, because we don't have a high pressure as we did in the arteries. So in order for blood to move back into the heart, we need other systems like the valves. You have muscle pump, which is like the muscles that's surrounding the veins. They with their action, it causes like a pumping motion to allow blood to move back into the heart. And then with breathing, for example, when you breathe, when you inhale, you're decreasing the intrathoracic pressure, and then when you exhale, you're increasing the intrathoracic pressure. So depending on if the intrathoracic pressure is high or low, it causes for blood to move in. So for example, if intrathoracic pressure is low, you'll have a pressure gradient that causes blood to move from down to up. And then you have a suction effect, which is when the heart pumps, during diastole with the filling, it causes like a suction effect. And you also have venoconstriction. For example, when the sympathetic system is activated, it causes for the veins to constrict. Then all you have to know about the lymphatic system, it just drains any excess fluid. So if there's too much fluid moving out in the capillaries, and for maybe the reason would be like there's less protein in the blood, so too much fluid moves out of the vessels, then it's drained from the lymphatic system, or we depend on the lymphatic system to drain. Okay, now talking about the specifics of blood flow, I think everyone has gone over this before. I don't know if you have actually, but you have laminar and turbulent blood flow. And laminar blood flow is a consistent blood flow that's moving in parallel lines, while turbulent is where it's a bit haphazard. It's got like these what's it called, eddy currents. Yeah, you have to know this name, like it's a very important terminology. Eddy currents, where it's not parallel but it's twisting, and it's just a turbulent characteristic of blood flow. And we have a formula to calculate Reynolds number, which is able to evaluate if what's it called, if the blood flow is laminar or turbulent. And it is volume into diameter into density divided by the viscosity. And if Reynolds number is between 200 to 400, it's where turbulent blood flow is only at branching points of the blood system or in areas of specific stenosis. Reynolds number, when it's less than 2000, then it's known to have low probability of turbulent blood flow, and if it's over 3000, then it's high probability of turbulent blood flow. But yeah. And then for blood pressure, we know there's a direct way of measuring blood pressure, which is invasive, and an indirect, which is how we do it with the stethoscope and the sphygmomanometer. And what you can hear when the vessels are constricted is called coronary cough sounds. The formula for the mean blood pressure is one-third of systolic blood pressure and two-third of diastolic blood pressure. Systolic blood pressure is the blood pressure during systole, and diastolic is during diastole. There are some factors that affect the systolic blood pressure, and there's some factors that affect diastolic blood pressure. I would recommend you reading the lecture because there's a lot of information about this. And then you have critical closing pressure. So there needs to be a pressure that's sustained within the vessels in order for blood to move through, because there's pressure already from surrounding structures. So in for the blood to move through, it needs a certain amount of pressure to be able to resist the resistance around it and still be able to maintain a blood flow and exchange. And so the arterial critical closing pressure that you have to know is 20 millimeters of mercury, or 2.7 kilopascals. And here are some formulas that you have to remember. It's just a whole lot of formulas you just have to know, especially the Hagen-Poiseuille's formula. And I just thought it would be helpful if you had it all in one slide. So we will be sending you this link at the end of this seminar. Yeah. But yeah, that's all from me. Now, Tandis.
Okay, hi guys. Okay, I'm gonna explain the conduction system of the heart. I think Katie sort of explained that the heart is a specialized tissue and it has automaticity and rhythmicity or whatever you call that. So what does that mean? It means that it can generate an action potential. And how is this like how is this happening? Using the conductive system. Okay, the conductive system is basically the cardiomyocytes, which are connected by intercalated discs and gap junctions, which makes the heart work as unit. Okay, it's as one. So basically, like it helps it work as like one system. And this conduction system, it has different parts. Okay, it has the SA node, which is one of the most important parts, is the primary pacemaker, and it's the fastest pre-potential. That's when the action potential starts, and then after that it continues through the atria, which it goes through the internodal atrial pathway. um it conducts to the whole of atria, and then after that it continues to the AV node. The AV node is basically the gateway between the atria and the ventricles. So it goes from the AV node to the ventricles. And from there it continues through the bundle of His, which are the branches in the interventricular system. In the interventricular septum. Sorry, that's wrong. In the interventricular septum. And then it goes to the apex, and then it goes back up, and the whole heart it would start contracting. We have some fibers also, which are called the Purkinje fibers, are which are under the endocardium. These are also part of the conduction system. These are like everywhere in the heart. So next slide. Okay, this conduction system, it is regulated by the autonomic nervous system. The parasympathetic nervous system, it will cause negative chronotropic and dromotropic effect. Chronotropic means increasing the means heart rate. Negative means it decreases the heart rate. So the parasympathetic will decrease the heart rate, and dromotropic means the velocity of conduction. In this case, parasympathetic will decrease the velocity of the conduction. In the case of sympathetic, which is using like hormones like norepinephrine, epinephrine, and all of that, it will increase the chronotropic and dromotropic effect. So it's positive. So it will increase heart rate and it will increase the contractility, and also like the velocity of conduction. And the next slide. I didn't mention the neurotransmitters and the receptors and stuff from the last slide because like those are stuff that you just have to memorize. It's nothing to like for me to explain. And then, okay, this is important. So the cardiac cycle, it is performance of the heart from the beginning of one heartbeat to the next one. Okay, and it consists of a diastole and a systole. Diastole is the relaxation of the heart, and systole is the contraction of the heart. Next slide. And relaxation, so basically diastole, it has two parts. It has relaxation and a filling phase. So during relaxation, all of the valves are closed. The myocardium is relaxed, and the intraventricular pressure is decreased, and the atrial pressure is increasing. So the blood will start flowing into the atria, and then after a while, when the amount of blood increases, the pressure of the atrial will increase so much that it will cause opening of the valve, and then the venous blood, it will directly go into the ventricles. This happens in the filling phase, and it is called diastasis. And then we'll have at the end of the diastasis, we have the atrial systole, where the atrias, they contract to empty the blood inside them into the ventricles completely. Then after that, the systolic phase starts. Okay, systole means contraction, and it has two parts: isovolemic contraction and ejection phase. In isovolemic contraction, so like you can notice from the name that the volume doesn't change. It begins when the ventricles start contracting, the pressure increases. So the pressure increases, and the pressure in the ventricles will be more than the pressure in the atria. It will cause closing of the valves. Okay, this is the first heart sound. And so the volume is not changing. It's just causing closing of the first valve, like the first heart sound, closing of the valves, so that blood won't go back to the atria. And then after that, this contraction will continue, and the ventricular pressure, it has to increase to that level that will be more than the arterial pressure, so that the blood arteries, like it to the aorta. And and this is based on the fact that like pressure, blood goes from where the pressure is high to where the pressure is low. Yeah. Okay, so next. And okay, so you have a graph which really helps you understand this whole cycle. It's just called the pressure volume loop. If you understand this graph, you don't even need to like memorize it. It makes it so much easier. It has like 4 points on the graph. I don't know if you can see it. It's like the quality of the picture is not the best, but like it's not bad. It starts from the first point, which is the mitral valve closure, and then after that we have the systolic phase starting, and the first part was what isovolumic contraction. The volume doesn't change. Um, the pressure increases and it will cause opening of the aortic valve. blood enters the Blood enters the aorta and the arteries, which that is part of the ejection phase, and this continues till because when blood is entering the arteries, so the ventricles they're losing the blood. Okay, so basically the pressure keeps on dropping when the volume of blood is decreasing, and this will cause closure of the valves again, and then after that the blood will continue into the arteries. So this is where the aortic valve closes. This will be the third point, and then after that we have diastole, which will be relaxation of the heart and filling of the heart. Next. Okay, so stroke volume. I think Katie or Alas like explained what stroke volume and all of this kind of stuff is. I'm just gonna explain it based on the graph that like what if they change, like what if preload change, what is gonna happen. So when preload increases, the volume doesn't change. No, sorry, the pressure doesn't change. The volume changes. It's only the volume that changes. That's why we'll have shift to the right. But when contractility is changing, when contractility is increasing, the pressure will also increase. That's why I don't know if you can see it in the picture. Like it's like more like this. It goes up a bit. And in the case of afterload, because so basically afterload is the pressure that it has to overcome. When afterload is increasing, so the heart has to put in more pressure to be able to eject blood. In that case, the volume and the pressure increases a lot. The volume doesn't change. Sorry, I can't see the pictures. It's a bit like hard to explain. But yeah, that's it.